Perfect. Thanks everyone for joining, and I'm really excited for this tonight's session because we rarely get pediatricians on, so I'm interested in this perspective. And Dr. Cohen Solomon, thank you for doing this tonight. You have an interesting, you know, entree into why you got involved in all of this. So, we're going to start with your presentation, but what I like to have each presenter do is just kind of introduce why they're interested in this work, how you got involved, and I'm sure you have a canned speech ready to go. So maybe talk a little bit about that, and then we can dive into your presentation. And as questions come up after the presentation, we can get all into those. So disappear for a bit and let you go for that.
Right, absolutely. And if anyone can't hear me, just chime in the chat. So I'm Sarah Cohen Solomon. I am a board certified general pediatrician. I am specialized in Ehlers-Danlos care, specifically hypermobile Ehlers-Danlos, and the myriad of complexities that tend to go along. So dysautonomia, Mast Cell Activation Syndrome, and my reason for all of this is that I'm a patient myself, of course, as so many in the field tend to be. And it wasn't 100% intentional. It was sort of one of those things where I was figuring out some next steps while living abroad, and my nice tidy plan path forward sort of fell apart underneath me. And then a position at Prism Spine and Joint in Silver Spring, Maryland, sort of became available miraculously at a moment that I was figuring out my next steps. And so for the last several years, I've been the general pediatrician there. And I say general pediatrician because what I do aligns most with a general pediatrician or a primary care, but I don't do well visits. I don't do vaccines at this time, um, but rather the complexities that tend to occur with Ehlers-Danlos and all of the complexities um, are very much the way a primary care physician needs to look at things. So, stratifying what risks we're looking at, what other conditions could it be, and really looking at all the systems of the body, not just one system of the body. And as I'm sure most of the family members and patients here can attest, most physicians are very narrowly focused on their area and only their area, whereas primary care is very much inclined to look at the whole body. And that's very much what I do. So my own lived experience very much goes into how I practice. I was diagnosed with Ehlers-Danlos when I was 20, dysautonomia. Must have been 21 or 22. But I'd had accommodations for symptoms for many, many years before that. High school was a very difficult time of my life, and I was very worried going into college because of how disruptive my symptoms had been, and we didn't have answers yet. So, I was very pleased to have accommodations. My college experience was very positive. My medical school experience was part very, very positive and part very, very negative. And so for me, being able to tie in my own experiences and how I want to practice medicine because of how I was treated both well and not well, it all came together in how I practice and treat patients now. So it's been a bit of a journey, but I'm really very, very pleased and privileged and honored to be able to use those lived experiences to, I hope, bring better and improved care to other people and make sure that others don't have the difficulties that my family did. So that's the quick and dirty about me. And I can share my slides if we're ready, or if you had something else first.
I We can get right into it.
Okay, let me
Okay.
see if I'm doing this correctly here. I'm going to go back over to my keynote, and then is that working?
Yes, perfect.
Okay. Now, I was able to see you guys before, and for some reason now I can't. So we're going to do it pretty much just, blindfolded. Off we
No
go.
worries. If something comes up, I'll unmute and I'll jump in there.
Fabulous. All right. So, technology for the win. So, hypermobile spectrum disorder and hEDS in kids is our topic for today. I just told you all about me, so we can skip that slide. So our goals are very general, and I want to make sure that we have plenty of time for questions. So I do want to review the history where we came from with what we know about HSD and hEDS currently, and really define both EDS, hypermobility, and make sure that we understand the difference. It's important to understand diagnosis for both of them because so many of my patients come to me feeling very frustrated that they can't get diagnosed. It's been so long. So understanding the diagnosis as it currently is. But also, I want to talk about how kids tend to present and how that might differ from adults. I want to touch on some of the new research because it's a big changing landscape, and that's very important. And a quick guide to accommodations. And then I already have a big, beautiful list of questions that were sent in advance, and off we go. So to start off with, EDS in general tends to get a bit of a bad reputation on social media these days because it's suddenly everywhere, or so we think. Except that it's actually not a new diagnosis. It was described, 2,000 years ago by Hippocrates. It's just that it's been very poorly recognized and poorly understood over that period of time. And it wasn't until the last 100 years or so that we finally started systemically sorting out which types of EDS were which, how we should classify them, and how we should evaluate for those. And then it wasn't until the latter part of the 20th century that we got the closer to our modern subtypes. So in 1997, the Villefranche criteria were proposed with 6 subtypes. Before that, it had been 3 and then 5. And then in 2017, I'll go through the relatively current adult criteria. But it wasn't until 2023 that anything regarding pediatrics was described or recommended at all. So, what is hypermobility itself? Hypermobility is not the same as EDS or hypermobile EDS, and it's important to make that distinction. So the Baton score, which was proposed in, I believe it was 1973, as actually a screening system for populations, it was never actually meant to be a diagnostic tool. What it does is it presents sort of an all or nothing score by age and sex assigned at birth to evaluate your range of motion. So range of motion at the joints. Often it's referred to as flexibility, although technically flexibility has to do with your muscles as well. Range of motion is literally how far your joint goes. And there is a normal range and an abnormal range. And when we're in the abnormal or too far range, we call it hypermobility. That can be in one joint, it can be in several joints, or it can be all over. When the Baton score is high enough, or we use other scoring systems to evaluate, we say that we have generalized joint hypermobility, meaning that the excessive range of motion is present pretty much all over the place. That doesn't mean literally every single joint is going to be hypermobile, but it gives a general view that yes, this person is generally hypermobile and it's not just a few locations. Now, that is not the same as either hypermobile spectrum disorder or hypermobile EDS, and we'll get into the criteria for each. But what's important to understand is that you can have joint hypermobility both locally or generalized and not have any other condition associated with it. Hypermobility is just a trait. It doesn't necessarily cause harm and it doesn't necessarily cause problems unless it is associated with other issues like instability, which is where we start getting into pain and injuries. Now, the Baton score in and of itself is debated as far as whether or not it's very accurate. It is skewed towards the upper joints, so the fingers, the hand, the elbows, and doesn't necessarily take into account, or it doesn't at all take into account the neck, the hips, for example. It seems to be, oddly enough, most reliable in my precise age bracket, so ages 6 until 12. But there's really no agreed upon range or test for anybody under age 5, and that's an important detail because little kids are always going to be more flexible than they're going to grow into as adults. So judging a 2-year-old for being very flexible or hypermobile is different than judging a 40-year-old. Now, it's not well defined in terms of its accuracy for gender nonconforming individuals or trans individuals because we do know that there's a hormonal element to joint flexibility and hypermobility. So it's not a perfect representation for everyone, and more improvements definitely need to be added. So, Ehlers-Danlos syndrome, EDS, it's important to understand is actually a group of connective tissue disorders. Most of them include hypermobility as a feature, but they also have other distinct qualities that make it clear, if it's classical, vascular, hypermobile, etc. Now, there is some overlap in the features between them, so it can look a little bit blurry. But what's important to understand is that genetic testing is available for the specific mutations that cause all of the other 13 types of Ehlers-Danlos, except for the hypermobile type. Now, unfortunately, the hypermobile type makes up about 90% of EDS cases. So it can feel very imbalanced. The other types are still genuinely considered rare. So the classical type is 1 in 40,000, the vascular is 1 in 200,000, and some of the others, which have long, complicated names and aren't relevant for the rest of our talk, are actually closer to 1 in a million. The HSD and hEDS population most recently is suggested at 1 in 500. So it's not really considered rare anymore, but it is still treated as a rare disease, and that makes it difficult to get care. Now, in 2017, the international consortium worked out basically this scoring system to create a more streamlined approach to diagnosis. It was also intended to help with research and access to treatment. So it is not a perfect system, and it was never meant to be a perfect system. So a lot of people feel like it's too rigid, pun intended, in some areas, and then too, again, pun intended, flexible in other areas. But in 2026, they are planning some updates. So that's outside the scope of this talk, but it's important to understand the 2017 criteria for context before we talk about the pediatric 2023 criteria. So the first thing you'll note is that criteria number 1 is, do you have generalized joint hypermobility? Now, this can be a little difficult because as we age, our joints aren't necessarily as flexible as they were when we were younger. Injuries or surgeries might get in the way of our flexibility in a certain area. I'm not sure if you can still see my pinky, but my favorite way to explain that sometimes the score isn't accurate is that this pinky joint tends to be a little dislocated most of the time. It doesn't cause me pain or problems, but when I push on it, normally it goes to about 45, maybe 50 degrees. Unless I put it back into position because I do this for a living and I can do that. And now it goes just about past 90, but I'm almost 40 and I'm not as flexible as I used to be. So it's a perfect representation that not everything is always as it seems. For older patients, there is a historical question set of 5 questions that can be asked to say, hey, maybe you're not hypermobile now, but we can get a historical understanding of how flexible you were, and this is considered very accurate. Now, if you pass this gatekeeper with enough joint hypermobility, you go on to criteria number 2, in which we are going to look at skin and soft tissue. So scarring, things like the papules that you can see here on the heel, other areas of the body that might indicate that the soft tissue is flexible or lax. We're also going to look at family history and joint instability as evidenced by injuries or pain. Now, you only need 2 of these 3 features within criteria number 2. And then for the soft tissue, you only need 5 of 12. Now, anybody doing the math might be able to notice that if you have a direct family member who has the diagnosis, you actually don't need that many other symptoms or signs in order to qualify for the diagnosis. So that can be a little bit frustrating because it's almost like a backdoor into the diagnosis, some might say. Now, criteria number 3 is really that I, as the physician, need to make sure that it isn't a different condition before I diagnose you with hypermobile Ehlers-Danlos syndrome. And we're going to talk a little bit more about genetic testing in a second, but my general approach is making sure any joint swelling, rashes, or fluid in the joints is ruled out, and it might lead me into a more rheumatologic, like arthritis kind of diagnosis. Injuries that might have caused the joint flexibility instead of the connective tissue itself, things like that. But there are other connective tissue disorders to rule out too. Now, One of the limitations is that HSD, hypermobile spectrum disorder, doesn't really have its own set of criteria, but rather we say if someone nearly meets hEDS criteria, but not quite, they get an HSD diagnosis, which can feel very unfair because it is. And we're hoping that in the next couple of years, we have some better criteria to work with. Now, pediatric criteria has been very, very limited. It's still limited, but it's better than it used to be. So until 2023, we were working off of this adult criteria in order to diagnose children. Now, this was frustrating because in feature A, so your skin and soft tissue, there are some areas that someone might not have experienced yet. So, for example, multiple atrophic scars like you see. Oh, there's my mouse. Multiple scars like this that you see in the corner where the skin hasn't come together to heal very well. Well, if a child hasn't fallen down enough times to have a scar, it's not that they have a different diagnosis, they just haven't developed all of the signs of it yet. So that's been frustrating and tricky. Now, moving into 2023, we still have our hypermobility score. So, in children who are not yet considered done growing, the score was set at 6 and above, so 6 out of 9. But there was a lot of good that came with the new framework and a lot of questions that came up as well. So, our goals with the new framework was that basically we wanted to be working with pediatric diagnostics, data, as opposed to adult data. So this was a good step in the right direction. We also wanted to make sure to avoid early dismissal. So if you do not fit all the adult criteria, we don't want someone to go to a specialist and be told, no, you don't have hEDS, you can stop looking into this. And then several years later, backtrack to find out that, yes, they do. They just didn't meet all the criteria yet because they were young. Now, I don't have a good representation here because the picture is very just complex, but it also provides a flexible spectrum. Again, I love the pun, for monitoring. So it suggests that you might not have all of the full-blown features at any given time, but you're still in the spectrum of hypermobility syndrome that needs to be monitored. So the benefits for these criteria is that it's almost a little bit easier to meet some of them. So instead of 2 scars, only needing 1 scar and things like that. And it helps to prevent that early dismissal. So keeping people in the loop. And it does acknowledge that it is a spectrum of conditions and severity of conditions. So I like that as well. Also, you'll see at the bottom that for the first time, select comorbidities were included in the criteria, which is extremely important, especially since the newer research really shows that other complexities are so common with hypermobile Ehlers-Danlos syndrome that it almost calls into question why we don't include them as part of the diagnosis itself. So that's a big topic for another day. Now, what's difficult about these criteria, and a lot of people have been left frustrated, is that instead of using the term hypermobile Ehlers-Danlos syndrome, what they recommend is that anybody who's not yet skeletally mature or done growing is given a term underneath the umbrella of hypermobile spectrum disorder itself. So we've sort of broadened the spectrum, into more categories. Now, what I like about that is that, again, it keeps more people from being dismissed before they're diagnosed. But a lot of people feel, and myself included, that the new names are confusing. They don't have their own new coding system for billing. And also, it sounds like we're saying you can't have a genetic condition until you turn 18. I have spoken to the authors of the paper, and I hope that I am quoting them appropriately when I say that they really never meant for that to be the case. And indeed, several of the authors are actually still using the hEDS terminology for younger individuals. The intention of adjusting the criteria was actually meant more to put a spotlight on the idea that if you have, say, a 3 or 4 or 5 or 6-year-old who is already showing very significant symptoms of these connective tissue disorders, it's a very good idea to be extra certain that you're not looking at something else that might be even more severe or even more concerning for their general health because of how early they are presenting. So I am still comfortable diagnosing hEDS in younger individuals if they are already meeting adult criteria and if they are likely done growing or even younger. But what I'll do is on the paperwork in my note, I will explain that I have used both the new and the old criteria. Here's where they land on the new spectrum labeling system, and here's where they land on the old one, and that my goal is to get them the best care available based on what we know and what we can. And I'm very comfortable with that balancing act, but not everybody is. So now, genetic testing, like I mentioned before, you cannot directly test for HSD or hEDS. But if I hear that either they or a close family member had either an aneurysm at a young age, early hearing loss or deafness, cleft lip or palate, these are signs that are going to lead me in a different direction and make it all the more important to order genetic testing and rule out other conditions. Now, I am always very cautious. I don't like ordering genetic testing on everybody because, one, most of my patients are under 18, so they are not doing consent for themselves. And two, something that can come up is called a variant of unknown or uncertain significance. And essentially, what this is a mutation in what I like to call the neighborhood of other connective tissue disorders, and it may or may not have anything to do with your condition. Most of the time, we consider these to be benign or not alarming, not likely causing your disease or your condition. But sometimes there's a bit of a mid range where we're just not sure. But either way, if you point that out to an 11-year-old, they now know this for the rest of their life, and that can just feel alarming. And I'm not always comfortable with that from an ethical standpoint as a pediatrician, unless there's a good reason that I send for testing. Now, there's ongoing debate about the utility of testing, and I'm always open to change my mind. But right now, that's where I personally stand. However, future testing, we have a lot going on in the research. So this is a technical slide, but the most important features to know here are that these were a couple of breakthroughs. This slide is only up to date as of, I want to say, August. There are more exciting things to add, but I don't have a good summary of those. First of all, a team in Italy was able to identify a fragment of broken down, basically connective tissue that was very readily identifiable in HSD and hEDS samples or samples taken from those patients, but was not present in other types of connective tissue or joint conditions. And that's an opportunity for a possible lab test for the future to identify the condition. Now, many other people might have heard about the MUSC Medical University of South Carolina breakthrough several months back in the kallikrein gene family. I won't go through this study; it's very detailed and phenomenal. But what that study suggested was that there is a link between the kallikrein 15 gene variant that they found in a particular set of families affected by hEDS and other families with hEDS. And then they basically created a mouse that had this genetic mutation, and the mouse had effectively Ehlers-Danlos syndrome. So there's a lot of possibility to use both these breakthroughs for future testing and a more objective diagnosis, which would be wonderful. But I will also throw in that the updates since the end of the summer also suggest that their same MUSC team, that there is a much, much larger role from the immune system that we hadn't previously encountered in research before. It's been suspected for a while among specialists that the immune system might be playing a role because so many of our patients will have like either an illness or an injury or some big event in their lives, in their body, and then their body is like, all right, I was just flexible before, but now I have symptoms that I can't control and can't tolerate. And it's like a switch was flipped. And that's a very immune system red flag for a lot of us. So more to come on that. Now, Many of you watching have probably experienced how difficult it is to find a unifying diagnosis because the symptoms can be so widespread, and it's often likened to this concept of if you blindfold a bunch of people and tell them, examine this elephant, you're going to get very, very different reports back. So the tail is going to feel different than the tusks, is going to feel different from the ears, which is very much how our patients experience this condition. Because this is what it looks like. The lived experience is widespread. So, yes, you can have the more obvious connective tissue involvement of poor wound healing, abnormal scars, hernias, joint injuries, joint dislocations, but you can also have organ shifting, including prolapses. You can have heart involvement, nervous system involvement, obviously, Chiari involvement, things like that, GI system, all sorts of things. And the list really goes on and on and on. But when the list is that complex, most physicians kind of panic or tune out or both, and don't know how to connect the dots. So my biggest recommendation whenever I'm talking to physicians is that if someone comes in with all of these different pieces going on and you don't know how to connect it all, or you don't think there is a connection, start thinking about a connective tissue disorder, because that might unify your thought process. In kids, hopefully, most of the time it's not always as advanced, but unfortunately, if it's not recognized early, it can feel that way. Now, I want to clarify because one of the questions I get most often is this a condition that is degenerative? Technically, no. And by that, I mean, does this condition automatically absolutely get worse the way we might see in MS, for example, or Huntington's, where we know if you have that diagnosis, there's really no preventing it from worsening. That is not the case in HSD or hEDS, but it can often feel that way because a lot of the research and the history is that people haven't gotten good care. So it can often function like a condition that's going to devolve, but it isn't necessarily that way. So for kids, the hypermobility and the joint instability is often going to look like growing pains. I am personally very triggered by the phrase growing pains, and I should have put up a little warning there because I know many of you might be as well. But growing pains that are ongoing, waking your kid from sleep, really not growing out of or responding, to Motrin or Tylenol, that needs to be evaluated further. But also, if a kid is unable to participate in regular kid activities, gym class, sports after school, just running around with their friends, and you notice that that kid is just always the kid who needs to lay down to rest first. They always need more time to recover. Those are things to look out for. It's not necessarily EDS, but those are still things to be watchful of. Neurologically, headaches, dizziness, fatigue, pain again, having difficulty with your sleep quality. And the dizziness is also possibly cardiac in nature as well. So POTS can occur in young kids. The younger the kid, if there's a dizziness issue, a heart racing issue, the more worried I am that it's a different form of maybe a genetic dysautonomia. So again, we have to rule out other things too. It's important not to just, pigeonhole people. And then GI symptoms. So constipation, I would say, is my most common symptom for kids, especially going way, way, way back into childhood. But diarrhea can be common as well. It can alternate, certainly. But a lot of kids will just have difficulty with their food intake, either because they're having difficulty swallowing, with taste, with chewing, with textures, or digestion itself. And food sensitivities may be because of allergies, maybe because of eosinophilic esophagitis is common, things like that. So again, we see here a very complex, widespread set of symptoms. And as such, it will surprise no one that that can affect quality of life. So for kids, we want them to be active. We want them playing and enjoying themselves and learning and running. But if it hurts to do regular activities, sitting, standing, etc., then playtime can be kind of a chore. So some of these kids develop the habit of being what you might call homebodies or bookworms, activities that don't require as much movement, which, by the way, are great activities. But if it's because your body isn't holding up and you're not able to participate, that's a different story. But they might not be able to comfortably get around their school building without pain. Gym class and sports might become a difficulty. Holding a pencil or keeping up in class, again, these are things that we can address as well with some accommodations, but it's important to make sure they're not holding a kid back. Generally, the system that might just be sensitive to, so lights and sounds and smells might limit your ability to participate in activities. And then the fatigue and the brain fog that can come along with it can make it hard to think and function and pay attention in school and have fun with your friends. So all of these things together, as well as, just time spent out, can contribute to feeling like, you're not really part of your friend group, and your social involvement and your identity might get involved too as a kid. And that's something we want to address and work with. So one skill that I like to teach people is a traffic light system because, and I really wish this phrase would just evaporate and never be used again. But school avoidance is a term that is very commonly used. I hate that phrase really because if a kid is having trouble functioning or going to school, there is a reason. Kids want to be with kids their own age, generally speaking. So if they are unhappy or unable to go to school, we need to figure out the underlying cause that is making that difficult for them. So one of the ways to help with this, if it's related to chronic symptoms, is to reduce decision making on the difficult days. So what I like to say is, first and foremost, you have to plan ahead with this. It's important not to leave it to the last minute. There needs to be an agreed plan before the morning of school. So, it's fairly straightforward. On a green day, we're going to school full time, no big deal. Symptoms are pretty well under control. That doesn't mean it has to be perfect, but it might mean that it's good enough so long as you have your school accommodations in place, for example. But the bottom line is you're there. On the far end of the spectrum, we have red, we have symptoms that are flaring out of control. We've tried appropriate interventions and it's not working. We are staying home. The middle range is where it tends to get frustrating and tricky for families because it's murky. Symptoms are subjective. It's not like we can try 2 puffs of albuterol and see if we're breathing better and then go to school. It's just more complex. So what I like to recommend is, first of all, we're going to talk about some interventions in a minute, but there might be an in-between range. So if someone's symptoms fall in their mild to moderate, maybe they skip the first class and then they go in for the second class and they stay the rest of the day. Or we say, all right, I see that you're having a hard time. Let's make this a half day as we've previously agreed. I'll pick you up early so you don't have to face the whole day. Because that's, it's easier to face half a day than a whole day, right? How about we just drive to school and when we get to the parking lot, we see how you're doing. I will sit there during your first class. And if you can't make it out, then, we'll go back home. Or something similar to that. But the idea is to have a graded approach in advance so that it's not a negotiation every single time it happens. Now, decision trees and menus can be very helpful for interventions for these days, but they also help with self-management and self-reliance, and can reduce all that decision fatigue. When everything hurts or everything is exhausted and it's just tough, adding on top of that the decision making, the thinking for yourself, it's hard, it's a lot. So this can really be very helpful and reduce that burden. So I like to call this my I don't feel well tree. And it's very straightforward. I don't feel right. I don't know why. Let's start looking at the possibilities. Am I thirsty? Yes. All right. Drink water, electrolytes, or just try it and see. Am I hungry? Yes. Have a snack. So it's not a brilliant list so much as that it takes the thought away. You just don't have to think for yourself, which is very nice sometimes. So it walks you through a couple of easy, simple interventions to see where you are. And if you can use one of those and then feel better, great. You return to your normally scheduled day. And if not, you can go over to your pain menu, for example, and look at your options that you have prearranged as things you can do to help feel better. So for me, for example, I've got my lovely, heated pack behind me right now. Often, an Epsom salt bath. whatever other pain relieving measures you and your physician and your team have worked out can go on a lovely menu so that you just don't have to think it through each and every time a symptom comes up. Now, with those in mind, let's assume we've gotten to school and now we need to talk about some accommodations. Right now, things are shifting somewhat in the federal government. I'm not going to address too much in terms of those concerns unless people have really burning questions. The bottom line at this time is that all of the laws are still in existence. Some of the support staff to make sure that special education is available and being administered appropriately, that is what is under question at this time, or not, possibly not available. We'll see where those things go. But for a very general sense of background, we have the federally funded public schools through grade 12 versus not, so a private school. And then we have college and above, and those are under a different set of laws. So the individualized education plan and Section 504 both apply to grade school through high school for public schools. And within this, so we have the free and appropriate public education requirement, and that says that accommodations are appropriate and needed. And then we also have the individualized education plan falls under the Individuals with Disabilities Act. So the IEP falls under IDEA. And I said that a little bit poorly, so I apologize. And then when we get to college or the workplace, the focus shifts. We're no longer talking about educational access as a right. We are talking more about access as an opportunity, or excuse me, as college as an opportunity. So we're talking about access as opposed to the intention being success in your public school education. And with that shift, the laws are just a little bit different in terms of what is required of the institution. Now, to sort that out a little bit better than I just explained there, we have 504 and we have IEP. 504 is under the Section 504 of the Rehabilitation Act, and IEP, Individual Education Plan, is under IDEA. That's the one that's a little bit hazier right now in the Department of Education. However, they have different purposes that overlap. So a 504 plan has to do, the way I like to explain it, more with medical concerns. It can be really any disability whatsoever, and it provides accommodations that don't have to do with the curriculum. All right, so we're talking about bathroom access. We're talking about taking pills, in the nurse's office. We're talking about adjusting the location of your classroom for access or elevator access, things like that. So more medical. IEP has to do with adjusting the curriculum or the set goals of the curriculum depending on an individual's needs. This can get more into the Department of Special Education, for example, but the distinction is really that the educational goals are adjusted in an IEP, whereas they are not in a 504. And there's a whole spectrum of what that might mean. And there is some overlap. So ADHD, for example, might fall under either one, but it just depends on the individual and your school system. Both of these are legal documents. They are binding. The school is required by law to abide by these documents and have a similar process of evaluation with a team to evaluate the kid and what their needs are in the school system. And the parent can supply additional background information like doctor's letters, specialist testing, things like that to support the needs of the child. But ultimately, the school, ideally with the parent, will work out a plan, whichever plan is appropriate, and go from there. Most of my patients are under the 504, but I do have a few with IEPs for other reasons as well. Now, sidebar, some schools will offer something called an individualized health plan. These make me a little bit mad because they sound very formal, but they're not. And a lot of the time, it's just an easy way for the school to do a little less paperwork. Now, sometimes it's just because the school has a system for, making sure that the nurse has medication forms, well organized or whatever. Fine, that's great. But sometimes it looks like a 504, like an easier version of a 504, but actually an IHP has no protection under the law. It's just determined by your school or your county. So if they're saying, hey, let's just do an IHP, it'll be easier on everyone, always suggest a 504 plan as well, even though it's more labor intensive, because there are more protections that go along with it. For example, so I want to emphasize anytime I'm creating a school accommodation plan, my goal is to emphasize or optimize what a student can do, how long they can be in school, and not penalize them for what they can't. And this is going to look different for everybody. And it's important to recognize that that's okay. So when we're talking about mobility and pain, I want to emphasize things like accessibility. So elevators, ground floor classrooms, having a pass that allows you to either leave early or arrive late without penalty so that you're not in a crowded hallway or racing across the school building, because we don't want you to get to the classroom and then have no energy or be distracted by pain so you can't learn. There are all sorts of tools to write with or type with or sit, better in a more comfortable chair, all sorts of things to make your body feel better. But I highly recommend breaks during the day. And I recommend having a very clear medical plan as well for what happens if things change while you're at school or have an emergency. From a using your brain standpoint, these rests are even more important, but I generally recommend having extra test time or delayed exam dates just to take that extra pressure off. Having access to your water and your salty snacks usually goes without saying these days, but having additional absences past the normal number can be absolutely, life-saving. Technically, that is a federally protected situation. So if someone has a chronic medical condition and are absent beyond the normal numbers, they're not supposed to be marked truant for that. But a lot of schools will put people through a lot of, hoops to jump through because of their rules. So the number one thing I recommend to parents is to always document why your kid is out of school. So even if it's a doctor's office visit, physical therapy, whatever it is, symptoms flaring, whether or not you talk to the doctor, make a note of what was happening on that occasion. Maybe send the doctor a little portal message just to keep them in the loop, and then you have, a paper trail. But the idea is basically saying if it's related to the chronic illness, it's not truancy, and that gets really muddled a lot of the time and puts people in very stressful situations. To that end, I say the support and mental wellness aspect of things is really tremendously important. But because of how often patients are unfortunately gaslit and struggle to find good care, it can be hard to be vulnerable and put this piece into play because it's scary. So most of the time when people have a chronic illness or get a new diagnosis, there's a process of grief and adjusting your identity that is hard. It's hard. And it can be a whole process to learn to trust your body all over again with this new information. But it's really important to have the right professional to support you during that. And that's not at all the same as saying that any of this is in anybody's heads, so much as that this is hard. It's a burden, and mental health takes a toll as a result. And especially because with these symptoms, it's very easy to pull away or lose your support system. So making sure to stay engaged in whatever way works for you is really, really key. So even adjusting the expectations for a kid by saying, yeah, you might not be in, a lot of my kids, for example, are on online school programs. Fine, there's nothing wrong with that, but that does mean they're not getting social time. So let's find other times to be social. And please, dear God, don't take social time away as either punishment or trying to emphasize the goal of saying, well, if you don't have the energy to go to school, that means you can't see your friends. They're different energies. And it's important not to take away that social time so that kids don't grow into adults thinking that they don't belong in or have a right to be part of the community if they are disabled. So we want to adjust that message. And above all else, keeping and finding joy and purpose can really change the way a kid grows up into an adult. So absolutely emphasizing that is more than important. And Yeah. All right. Those are my slides. I'm pretty sure that QR code is going to bring you to my personal website. If you're interested, feel free to follow, and I will see if I can shift my screen now so that we can start questions.
Awesome. That was great. Thank you so much, Dr. Cohen Solomon.
Sure.
I actually want to start with something based on one of the things that you had mentioned, just because I think it's important and it's not well understood, but there's some theories about it. So, can you kind of go through what the medical theory is of how a big immune reaction can cause an extended chronic illness? So, I'm thinking of stuff like there was that thing with Epstein-Barr connected to MS. Lyme is a big one, and now we're talking about this. So, I don't know if we could talk about the theory behind that.
So the simplest way I can describe it is that I like to think of it as the body just taking too many hits. And if there are any immunologists listening, I'm really sorry for explaining it
You're
that
good.
way. I like to break things down because I am a pediatrician. But yeah, so essentially your body is usually pretty good at keeping out bad things, attackers, etc. But everybody has their limits, let's just say. So for one thing, if a body is just taking too many things, I'll give you a great example. For people who have had the chickenpox virus as a child, that is a thing that still happens. When they become adults, they might develop shingles because it lives in the body and can kind of crop back up occasionally to be obnoxious and cause pain and symptoms. But the most common times at which that will happen is when someone has experienced a huge amount of stress. So the stress, I'm not saying stress caused it, but stress can bring down your body's ability to fight off either infections from outside or things that are brewing on the inside, and allow something to crop up again. So shingles is a great example of that. But there are all sorts of examples more and more that we're learning about viruses that can linger in the body. And I want to be very, very clear that most of them cause their symptoms and then go away and are, a thing of the past. So I don't want everybody panicking about every single cold, but we are learning more and more about how they can linger and affect your body's repair system, your body's ability to recognize itself versus attackers, things like that.
Thank you. And that kind of segues really well into this first question. So it says autoimmune disorders, fibromyalgia, even anxiety can end up looking a little bit like EDS, and it can cause misdiagnoses. I know you know all about this. So how do you know something is being caused? You talked about it a little bit, but how do you know it's caused by EDS, but not any other condition with a similar symptom?
Yeah. So kind of, first of all, it depends on if an individual has both confirmed diagnoses. I don't always know which underlying diagnosis, is causing the symptom of the day. All right. Because bodies are obnoxious that way, So you can have symptoms of, the simplest one is joint pain due to multiple different things. And by the way, a person can technically have rheumatoid arthritis and also HEDS. I almost feel like the two want to cancel each other out, but they don't technically. But you can have joint pain for multiple reasons, and sometimes the key there is just to find the right band-aid for the symptom, even if we don't know which problem it is. Other times, if we're lucky, we can identify a little bit more of a cause and nip it in the bud a little bit better. But we're just not always that lucky. Medicine needs to keep going a little bit more. Now, if we are still figuring out our diagnosis, uh, I was trained, and I hope others were as well, to look for various red flags. But I'm also really, really careful to keep a lot of things in mind at all times, because you can have one diagnosis and then develop another one just for fun. And unfortunately, we all have cognitive bias or anchoring bias, where we say to ourselves, well, we already have this one, so let's not borrow trouble and assume it's something else. So at the end of the day, we have to be, really careful detectives, and think everything through, and that can be hard. So, um, signs of a rheumatologic condition often include like a very swollen joint outside of an injury, especially if it happens over and over and over again for more than 6 months. Warmth fluid in the joint, redness, rashes over those joints, especially. There are certain very characteristic rashes that go along with certain specific rheumatologic conditions that I memorized for boards. And now, if I just see one of them, I say, off you go to a rheumatologist instead of trying to diagnose it myself because I know my limits. But oftentimes, I will say honestly, if someone's already seen a rheumatologist before they see me, I'm thrilled because then I can be really, really comfortable. It's not one of those problems, it's mine. So that always makes me a little happy. But it depends, and it's a complex situation. Fibromyalgia is especially difficult because we don't understand it very well either. And in general, I will say that people with HEDS seem to have a 3 to 5, maybe higher times risk of having an immune condition along with it. So it's more studies needed.
Probably a good one for you is put together questions we got in early, growing. And follow-up question is getting
Caitlin,
older,
sorry,
any new
I'm getting static.
again?
I don't know if others are as well. I think we're better now. Can you repeat that?
Yes, can you hear me?
Yes, perfect.
Sorry, I don't know what that is.
No worries.
So asking a question about when the skeleton is kind of done growing, and then following up with a puberty question. So are there any new orthopedic or hormonal issues that parents should be monitoring closely in that age range?
That's a good question. So formally speaking, skeletally mature means that the growth plates have closed. We are done growing. There's literally no more room left for the bones to do that. And in the endocrinology world, they will evaluate that for growth conditions by getting an X-ray of the hand of the forearm, and literally measuring. They have very detailed tables to show you whether or not you're skeletally mature. The rest of us will estimate that typically based on how far out you are from the beginning of puberty and various signs that go along with puberty. Most obviously, when how old you were when you got your first period. So for people who menstruate, that is a pretty easy indication of how far along they are. Honest to goodness, one of the authors that I spoke to said that, if they're already a year out from their first period, then that author was comfortable, evaluating as if they're an adult. I've heard others who say 4 or 5 years. We keep saying, hey, we've got really, solid information now, and then we all look at it and say, wait a minute, there's more to do, and that's normal. That's science. So it is okay when that happens, even though it's frustrating from a patient side. It's frustrating for us too.
Yeah, the
So
women's health is a nightmare, so I get it.
this is true. This is true. But in terms of going through puberty, that is a known, I don't want to call it a risk factor. It's a known trigger, you might say, for that before and after sensation for a lot of patients, unfortunately. So for some, like myself, for example, childhood was, very bendy, and other people noticed, but sure, a little more tired than the other kids. Oh yeah, growing pains. Oh, weird. All right. And then, growing into adolescence, oh, now we've got the clear symptoms, so I can't prevent that, unfortunately. Maybe one day, but not this day. But in general, I would just say, if you are noticing that your kid, your teenager, is not how they were before, tell your doctor for sure. If they are having pain that doesn't go away with reasonable efforts like Tylenol and Motrin and an appropriate amount of rest, tell your doctor. But I wouldn't start like not letting kids participate in gym without an evaluation, for example. If they're having pain, that's different. Don't do things that hurt. Maybe try PT first, for example. But I don't like the idea of telling kids, oh no, there might be this thing wrong. You can't do things. No, I want kids doing normal kid things. So yeah, that's
So
important.
that's a good segue to one of the questions. So this person's talking about their kids being able to play soccer again. That's coming up in spring. They're nervous, I guess, as a mom. So are there any modifications they should talk to coaches about? They want them to enjoy the thing that they like with their friends, but they want to prevent excessive absences as when things get started and stuff like
Absolutely. Yeah. So this is a little bit tough, because, we hear often, good parents will teach their kids that, the fun comes second and the education comes first. And that's certainly true. But we've also sort of set up a system, a culture in which there's very little, wiggle room for the other things that make life full and enjoyable. So, I'm okay with the idea of saying, all right, you get a couple of passes, a month or a semester, to mess around, learn how your body's going to go, and then find out. And you know what? We'll recover, and then we'll learn together, and that's okay. Again, I don't want kids growing into adults who think that they are only allowed in social settings and society if they are able-bodied. That's not okay. So sometimes we have consequences to actions, but then we learn. Now, in terms of the coach and being nervous, I totally, totally get that. First of all, I would let the coach know where we are in your diagnostic odyssey. So if we have a diagnosis, let them know. If we don't, but we have suspicions, let them know. But I wouldn't go overboard. What I would recommend is making sure that coaches or any athletic trainers are aware and keeping an eye out for good technique, for example. And look, no amount of bubble wrap is going to keep kids from an injury if an injury is going to happen, so I still want them to be having fun. If they are playing and they're having fun and it is not hurting, they are not having trouble at the end of the exercise, try not to worry about it. I know that's a really hard ask, but try not to worry about it. Um, my biggest recommendation for preventing any problems is actually really good shoes. Kids actually really should have sneakers replaced every 6 months. Sorry. And it should be a high quality sneaker. I'm so sorry. Like it's expensive. It's terrible.
that. I
And
know that made me upset.
I'm so sorry. But you know what? Shoes wear out and then you're not getting good support. And if your base, your foundation on the ground isn't strong, everything above that is going to be lousy too. So, it's just like going to fold on in on itself, and that's no good. So what we want to do is, make sure your shoes are good. Some kids might benefit from a light taping or a light brace. I would not recommend anything that really prevents movement because then other joints are going to try to overcompensate, and now we're going to have new problems. So don't do that. But yeah, the awareness, a little bit of preventative with the good solid, shoes and some ankle support, maybe knee support depending on the kid. But also teach them good habits as far as warm up and cool down, making sure they're in tune with their body, learning some skills about how to advocate for themselves, and it doesn't have to be complex when they're little. It could just be something like, my knee hurts. Let me tell the coach, and then the coach has a plan, or my knee hurts. I'll tell the gym teacher that I can walk today, but I can't run today. Very, very simple, straightforward. And that's a skill that's going to carry over, and that's super, super important.
This is actually a teacher, first grade teacher. One of my students has HEDS. His mom says it's hard for him to hold onto the pencil because of the joint pain. I
Yeah.
guess so his handwriting's a nightmare. What accommodations would be most effective to ask for in the IEP besides being able to type?
That is a great question, and I'm looking around awkwardly because I thought that I actually had an example next to me, but I don't know where I've put it. So some things that can be valuable are I don't know where it is. Anyways, there are all sorts of grippers that you can put on a pencil or a pen. So if for whatever reason it must be handwritten, you can use those. Not all kids like them. Some of them feel weird and it's just uncomfortable. So sometimes a just big pencil is better. So some of the like executive style not electronic, what's the word? Mechanical pencils have a really big grip that work much, much better. And you just don't, it doesn't need to be your number two pencil anymore. There's no reason. But alternatively, if you Google your way into either occupational therapy tools or ADL activities of daily living, and then tag on the word writing tools, you'll find all sorts of weird stuff. So there's even one that helps you write, like it's almost shaped like a wishbone so that you can hold it better. And I recommend having a variety. because each day might feel a little different for each kid, and that's important to be able to accommodate. Other accommodations are also to be able to take breaks, to shake your hand out, not feel crunched for time so that you have to press really hard. Some kids might benefit from either taping or little ring splints as well, so that their fingers have better feedback, and that can help to reduce the strain and the tension on the fingers.
Awesome. There's a question, there are a couple of questions in the chat I want to get to. So I'm going to start here because there's a lot of psychology. I'm sorry that we're going into this, but
That's okay. It's
what are your
necessary.
thoughts about participating in online and like in-person support groups for adolescents specifically?
Oh, strong positive, strong positive. I think it is extremely important for kids of all ages, but especially adolescents who are trying to find themselves to connect with other people who have similar life experiences. Not exclusively, they shouldn't only be talking to other kids with this kind of medical experience. They should also be exposed to all sorts of people, like we all should. But it is a different, very special experience to know that you're in a safe space with people who get it on a deep level. Now, sometimes people ask that question because they're a little bit worried that they're going to fall down a rabbit hole of either, the depths of the internet because, oh no, TikTok. By the way, there's some excellent resources online. Are they all? No, of course not. But a lot of it's actually solid. So I wouldn't knock it all off. But as with anybody, monitoring what your teen is doing online is appropriate regardless. So what we don't want is for somebody to the phrase came up the other day and now I can't think of another way to say it. We don't want it to become their whole personality. And I'm so sorry because that's such a weird way to put it, but I think people are using that phrase a lot these days amongst the youngsters. I just aged myself. I'm sorry. But we don't want your chronic illness to be the only thing that you feel that you are. And I realize that I have a bit of a weird standpoint for that because I have literally made it my job. And by the way, that's okay. Like if that is helpful and cathartic for you, go for it. But I also promise you that, I play with my dog. I enjoy music. I do art. I have other creative activities, so I swear I'm not a one-dimensional person, although it certainly can look like it. So that's what we don't want from those kinds of group activities. But most of the time, I'm going to say those are very, very, very positive.
That's great. And a good segue into another question about uh, you probably have a unique experience with this being a patient yourself, but how do you kind of move forward to the next part of your treatment and your management of your symptoms when you have a history of kind of being gaslit to an extent or just not being believed, being told no a lot? What are your recommendations or even resources
Um,
if it's adults or kids, like how to deal with that?
I'm tempted to make a joke and say when I figure it out, I'll let you know. But because I acknowledge that's a very very difficult subject. And I think the truth is, until you have a team that not only believes you but is also helping to genuinely take care of your needs, it's almost impossible to ask that of a person. Um, because it's sort of like saying, here, go take care of yourself and don't complain about it and then don't have any issues as a result. Like that's just not fair. So we do have to acknowledge the reality of those instances. um and again, I think it's very very important to have an appropriate therapist. I highly recommend trauma therapist specifically, because it is traumatic, and I think it is. I think by nature of it being about gaslighting, it is underappreciated how traumatic it is, and how deeply that can ingrain on a person who is growing up and trying to figure themselves out. So without getting too dark about it, there are a lot of techniques, EMDR specifically, that can help to process that kind of trauma, and kind of reorganize it in your brain so that it doesn't affect all of how you think about everything. So don't shortchange yourself for getting appropriate care and help. And tell people, it's okay to talk about these things. It's also important to make sure that you have other things about yourself to talk to. I don't want it to be the only thing that you have in your life. But not being closed about it is key too, because then it sort of festers and becomes like shame. So we don't want that. But yeah, it's a combination of factors, and it's not straightforward.
And then a question, there's a couple that I still want to get to that are in the chat. I'm going to
I'm
try
in
to
no
go
hurry.
quickly. I'm sorry.
No, that's
Okay.
fine. I'm a talker.
um, my daughter's not always able to keep up with her friends physically. She notices this is really upsetting her. It's like really upsetting mom to see that. Is there something that she can do specifically to help her feel less singled out since we're on that kind of train right
Oh, that's hard. So, it depends on the age, how to address it. So, when they're little, you have a lot more control over what kind of activities they're doing. So, if you're arranging play dates for a smaller child, you can more easily say something like, okay, other parent, we're not going to go to the amusement park. We're going to go to the movies, a seated activity, something like that. So it can be done on an adult level without necessarily making all the kids notice it if you're younger. But it's important as kids are growing to also help them develop a sense of language skills and self-advocacy skills so that they can say things like, hey, I'm talking kindergarten level words here. Don't make it harder than it is. That hurts my feelings because I can't do it. Um, can we do this other activity instead? And by the way, if the kids say no, they're mean. Make new friends. Um, and like, by the way, that's obviously easier said than done. Your circumstances might not always allow that. I'm sorry about the dog.
He's good. Can't hear him.
Oh, good. He's very loud on my end. Thank you. So as they grow, it becomes more and more their own responsibility as opposed to the parents' responsibility, and that's harder and harder. So the more those self advocacy skills are going to come into play. But they can do a similar kind of thing and say, "Hey, what about this other great idea that I had? Doesn't have to be because we're accommodating me. It can just be a great idea." And look, I can't get around the fact that sleepovers stink. They're hard and they're too much energy, and there just might not be events that you can always attend, and that's hard, and that might be something that you grow up feeling and have to work with. But that doesn't mean everything has to be that way.
Absolutely. Find a couple of questions. So there's a question about discussing the association of EDS with stuff like Chiari. I know you mentioned it, MCAS, arachnoiditis. Um, eh, so can you speak to that association? And then is if you're going to a neurosurgeon for a Chiari consult, how do you recommend you bring up the potentiality of EDS to them? Do you have like a recommendation for how you typically counsel patients to do that?
Yeah, absolutely. So, first of all, obviously, from my patients, they're coming to me as someone who is very familiar with the overlap with these symptoms. So they're often a little bit taken aback because they'll say something like, "Oh, and have you heard of this insert rare complication here?" And I'll be like, "Yes, you are my fifth one this week." And they're like, "Oh, so it's a little different." But first and foremost, since the connective tissue that we're talking about is really the glue that holds the body together, the way I like to think of it is that it can affect a lot of different areas, not just the joints. So if you look at your body through that lens and think of, for example, Chiari, where it's sagging through the opening of the skull, or the brain and the spine are sagging downwards, it makes sense when you realize that, okay, well, the glue holding everything up in a stable way is sagging. So a lot of the time when we start thinking about the body in a much more simple way, that can actually help to explain some of the more complex conditions. So vascular compressions are very similar. So we've got MALS, we've got Nutcracker syndrome, we've got SMAS, several different types. But the way I like to think of it is things aren't tacked down as well, and they shift. If they shift, they can also squash. If it's squashing something, it can be a nerve, it can be a vessel, it can be something else, and that hurts. No matter what, that's going to hurt. Simple as that. So when it's broken down that way, it's a little easier to kind of conceptualize. Now, if you're talking with a neurosurgeon or another specialized surgeon, the best advice I can give you is to start by seeing someone who is already familiar with EDS. And you can find people who are more familiar with that both through the Bobby Jones website, through the Ehlers-Danlos Society's website and registry, and places like that. But also, I highly recommend looking at the Facebook groups and other online forums because other people will have experience too. Now, caveat is that, of course, most of the time people who are most vocal are going to have had a most difficult experience because that's just the nature of life. When someone is happy, they forget to put in the review, and that's okay, but take everything with a grain of salt. POTS pun intended. So, we want to be cautious, but it can be excellent for finding people. So starting with someone who is already aware, very, very helpful. Now, if you feel like you have found someone who might be valuable but maybe doesn't have as much experience, then looking at the Ehlers-Danlos Society or the Bobby Jones or websites like my own at some of the primary literature, and looking at the scientific publications about the overlap of these syndromes can be much more helpful than saying, just as a silly example, oh, I saw it on TikTok. Don't do that. They will never listen to you if you say that. But if you go in with an article like, "Hey, here's my concern," that can be a little bit more compelling. Caitlin, I see you're struggling with sound again. Give me a little sign if you want me to read the next question off. One moment. Okay. Still not hearing you. I do have the questions you sent me earlier, so. Oh, very good. What are the, I'm on it. What are the signs that poor grades might be due to brain fog or, oh, what a hard question, or other symptoms instead of just a lack of effort in school? Is there any specific testing that we need to do to get the help she needs? Oh, great question. I'm glad you asked. Sometimes this is very, very difficult. First and foremost, there is neuropsych testing that can evaluate for things like ADHD, learning differences. Oh, Caitlin, now I hear you for a second. Great. And all sorts of other learning disabilities and et cetera, et cetera, et cetera. So it's definitely appropriate, and to get the school to pay for that, you can push them to pay for that kind of testing, but sometimes it's necessary to go private for faster, more thorough results, depending on your school system. But when it's a brain fog matter, we might not know until we treat it. So my I will never ever ever suggest anything other than starting with believing your kid. Especially if there's been a change. Believe it, trust it, kids are not as much into lying as you think. They want to be in school because that's where their friends are, and they want to be normal. They want to fit in. So, if they're saying it's not me, start with believing them and see what you can do about it. And also support them and give them the skills so that they can do better. I'm not saying just, throw it to the wolves there, but there's a lot that can be done. If brain fog is related to like blood flow changes in dysautonomia, for example, not only are water and electrolytes important, but I do not hesitate to medicate fairly quickly, maybe faster than other people, because I was a teenager trying to stay hydrated in high school, and it was not effective. It is, if you are trying to get good grades, you can't go to the bathroom in every single class. It's not going to work. And so you're not going to hydrate enough. And I don't know why we think that's going to work for anybody. So I am a lot happier to medicate more quickly if the family is on board with that once we discuss it, because they can feel a lot better. And if their brain is getting all that nice juicy blood, so good. So that can be huge for personality changes, for energy, for thought. So we might need to test a few things and see. Yeah.
Okay, can you hear me? Yes, there we go. I'm green again. I did want to ask about this because I feel like people know about it a little bit, but they don't really understand the physiology of it. So, what's that relationship between like a family history of aneurysm and EDS? Can you talk a little bit about that?
Ah, so technically, actually, if there's a family history of aneurysm, I'm worried that it is not EDS. So Marfan's comes to mind specifically, in having an early history of aneurysm. Now, aneurysms as people age are not uncommon. There were some research studies many years ago about some aneurysm risks of a much more mundane variety than happen with Marfan's. But those don't seem to be as big a worry with HEDS more recently, with the more recent literature. So it's not a huge worry in general, but if there's a young family member who had a significant aneurysm, that is an immediate, let me check for something else. And so that's going to get genetic testing for me, and an echo, including abdominal echo. So an echo is basically a heart picture. I want to know how the heart looks. I want to know how it's functioning. And for me, I'll send to cardiology for that so that it's not, just a read. I want to make sure they have a thorough appointment too, make sure I'm not missing something else. But most of the time, it doesn't need to be a specialist like a connective tissue cardiologist, although those do exist and they are great. Mostly, I just want to like do a good solid workup, rule that out, and then, get back to business.
Awesome. Okay, two last questions, really. This one's more targeted, the other one will be a little more vague. As far as telling the difference between generalized anxiety, I guess I'll have to say, versus anxiety caused by like chronic pain. A lot of the symptoms might be the same. You can have cardiac, gastrointestinal symptoms, all that stuff that kind of is overlapping. Does it matter where the anxiety is coming from? And would that
Yes.
treatment change?
Ooh. It matters because if you're telling someone that their problem is because they're too anxious versus anxiety is related to their body not doing what it's supposed to be doing, those are very different messages. Now, by the way, I think anxiety in and of itself needs to be respected as its own diagnosis. But I do think that in a world that humans were not evolved to be in, we have created a just catastrophe of anxiety producing signals. It's too much, and world altering events daily. So it's too much for kids growing up. So I want to emphasize that anxiety in and of itself absolutely deserves respect, unquestionably. But it is a different message to say that you are having all this trouble because your symptoms are a lot to deal with and your body is reacting and trying to process that. And it's become also physical symptoms of that produced anxiety versus a pure anxiety diagnosis. Um, Technically, one can treat them both with the same types of medications. It's not inappropriate to offer someone, for example, an SSRI, which are commonly used both for anxiety and depression. And in theory, they should work regardless of what the cause or underlying issue is. I will say that if that's the only thing that someone is offered and they are not offered appropriate treatment for their physical medical condition, it's not going to do the whole job. It's just not. But it might help to take some of the edge off so that it's easier to deal with, for example. Maybe you have a little bit more in your cup of energy to go to physical therapy to do some of the work involved in your body, then relearning to be safe, things like that.
Yeah.
So
And then I'm going to end on this question because I think it's good. So, and I think I know the answer, but maybe I'll reframe it a little. Do you let your patients and families know about your lived experience, and do you bring that up in the course of treatment? Does it help, and how would you say that would
yeah,
be?
that's a great. I mean, I think my online presence probably speaks for itself. But so yes, I'm very very open with my own diagnosis. Truthfully, a lot of patients come to me because they've already seen either my online content or some of the articles that I've written, and that has made them or their child feel safe to come and see me, which makes me so happy that I can do that for them. Because I did not feel safe going to doctors at that age. And if that is something I can gift them, I'm more than happy. I am not a private person. And that's fine. There's nothing wrong with that. I have several colleagues who do the same work and don't have the same drive and need to share, and that's fine too. And their patients aren't necessarily aware, and they still have great results and a great rapport, and they just think their doctor's amazing for no particular reason. So either way is fine for sure. But for me, yeah, it helps. There's an element of rapport. There's an element of them knowing that if they tell me something that might seem weird to somebody else, it doesn't seem that weird to me, and they can trust that, and that's good. So I am always happy to share. Yeah.
That's amazing. I'll end with, do you have any parting words of wisdom, and how can people get in touch with you if that's something that they want to be
Yeah,
doing?
absolutely. So I would say to trust yourself. It is if you are feeling that something is being missed or that your concerns are not being taken appropriately seriously, it is reasonable to go see someone else. And that hunt might take a while, and that stinks. And I hate that often that becomes its own battle of, oh, you've seen so many doctors. I wonder why. We should be suspicious. Try not to let that bog you down. Just be consistent, keep good records, and trust your gut as a parent. And I promise you, if my mom ever sees this, she's gonna cry. I promise you that believing your kid will help that kid grow into a much more settled, self-confident, well-adjusted grown-up than if you repeatedly tell them that you don't believe them or don't trust their assessment of their body, because that unfortunately adds to the sense that they're like, oh, am I making my symptoms up? Am I making a big deal? Do the symptoms not count because I can overcome them if I do XYZ? It's hard. It's very complex. It's very complex. But at its core, trusting your caretaker and your kid. That's what is, I would say, the absolute most important thing. And then trusting your doctor second. So, and
Yeah.
as far as getting in touch with me, I am the Bendy pediatrician. So you can find me on Instagram and Twitter. I'm not as active on Twitter anymore, but I also have a website, thebendypediatrician.com, and that's very easy to remember. And if you're interested in seeing me as a patient, you can go through my website to Prism Spine and Joint, or go to prismspineandjoint.com directly.
Thank you so much. And people are thanking you in the comments. Thank you for doing this. And thanks everyone for joining. And I'm going to send the video to you to kind of have a quick look, and then we'll make it available to more patients as well. So, but thank you so much for doing this with us
Thank
tonight.
you for having
You know,
me.
yeah, go home
Great
and
questions as
cuddle that
well.
dog.
Oh, he's on my lap again already. We're good.
Okay, good.
All
Have a
right.
good night.
Well,
Thanks,
Caitlin, good to
everyone.
see you. Thank you so much. Bye.